All right. This is the last little bit. It's basically focusing on the neurotransmitters. The transmitters, basically, and we name them the fibers that they release. So all of what they call the preganglionic fibers. It's a two-nerve circuit. The first nerve gives off acetylcholine. By definition, we call that a cholinergic nerve. It's less about that. If it's giving off norepinephrine, we call it an adrenergic nerve. But the key, and that's really what the focus point is of today, are the receptors. Because it doesn't matter so much what it gives off, it's what it does when it gets there. Okay? So, as you can see, those are the different things that you see. So, the preganglionic axons and all of the parasympathetic. So, acetylcholine is the only one for the parasympathetic system, whether it's pre or post. It's all the pre's in the sympathetic system, and the one post in the sympathetic system, that's the oddball, and you got to know about that. That's the one going to sweat glands because it triggers the sweat glands to perspire to cool you down when sympathetic activity, like particularly fight or flight. So that's really the focal points of the discussion. Some oddballs and specifics about it and how it interplays with medications. Very, very much so. The effects of the neurotransmitter depend on these receptors. We're going to classify them. Here's that illustration that you can see. And most of the time, they're stimulatory. There's a couple of oddballs that are inhibitory. Again, that's the critical piece to understand when it doesn't work the way you expect it. These are the fancy names. They named them for the chemical nicotine. Most of this chemistry was done in Europe. We were a very young country at that time. And when tobacco came over, they basically just wanted to see what chemicals were in it. Well, they isolated something and they named it nicotine. And then now they had a chemical to test with. And the same thing with certain strains of poison mushrooms. They isolated what they felt was the poison and they gave it the name muscarine. And it just so happens when they tested it, when they started testing this circuit, and again, it was one of the first circuits that they tested, these different sympathetic and parasympathetic nerves to see what their effects were. When they injected or gave nicotine, okay, what it did was it triggered certain receptors. So they just named them nicotinic. So all of the preganglionic ones are classified as nicotinic receptors. And again, that one oddball in the sympathetic is a nicotinic receptor. Everything else is muscarinic. I, I just think I just need you to know the terms. The way I would phrase a question would be, uh, the autonomic nervous system has, nicotinic receptors, muscarinic receptors, neither, both, that type of question. Typical Stein question. One of those that you incorporate multiple answers. So that's just naming the receptor. That's the ones that are associated with acetylcholine only. The more complexity and the more interesting ones are certainly the adrenergic receptors you're going to see in a second. So, for instance, the neuromuscular junction, and I never even commented on this, is technically a nicotinic receptors. Inside the adrenal gland that eventually produces epinephrine and norepinephrine, the first nerve that goes there, nicotinic receptor. All postganglionic neurons, sympathetic and parasympathetic. So that first nerve is always receiving acetylcholine. It's always stimulatory and it works fast. Acetylcholine opens ion channels, sodium's in, potassium's out. We already talked about that. And the interesting thing is it works fast. And remember, things that work fast typically go away fast. And that acetylcholinesterase is there, and that takes it away fast. That's why it's a very, very rapid agent. Moving ions in and out makes things happen fast, a lot faster, as you will see, than epinephrine and norepinephrine, which work by a different passage. And they go away fast. The muscarinic receptors, all cells stimulated by postganglionic cholinergic fiber, the acetylcholine that comes out of there. And here is the first key oddball. Can be either inhibitory or excitatory. They're effectively all excitatory. This is the big player. This is what your heart holds your heart rate in check. Your heart rate, and I commented on it before, the vagus nerve holds your heart in check. What it does is the healthier you are, the better your heart is controlled. Your heart would literally spiral and go very, very rapidly over 100 beats per second. So the healthier you have a healthy lifestyle, you maintain it. Particularly when you're younger, it's not as big of a deal. But all the bad things you do, like not exercising and eating wrong, maybe bad habits, drinking, smoking, all that type of stuff, okay, effectively over time limits that effect, and that's why resting heart rate is such a good indicator. If you're healthy, it should be between 60 and 80 beats per minute. For example, an idiot who smoked for 40 years, my heart rate before I stopped was over 100 at rest. I mean, that's a stroke or a heart attack looking at. Now it's where we're supposed to be, in between 60 and 80, somewhere in the mid 70s. If like some of you who are in sport or athletes or who are very seriously keep yourselves in shape, it might be less than that. That's not unusual to be in that 50 to 60 range, particularly endurance athletes. So that's the whole idea. Here, what it's doing specifically is lowering the heart rate. The vagus nerve, that particular receptor, that muscarinic receptor on the heart, slows the heart rate. And at the same time, it's inhibitory, but here it's excitatory. Because at rest, this is just thing, rest and digest, your heart rate slows, and because you're getting ample blood flow, okay, to your digestive and your genitourinary system, it increases. So effectively, those muscles become more active because they have more blood flow. So it's in concert together. You're going to see when we flip this and look at the effects of norepinephrine or epinephrine, but norepinephrine specifically when it comes out of a sympathetic nerve going to the heart, it accelerates the heart rate. That's fight or flight. And it also, because the heart is at that point designed not only to work faster, but to work harder, up to 3 times as much blood maybe being pushed around by it, it increases the force of contraction. This one is only about the rate. So the parasympathetic system is only about the rate. You're going to learn some fancy terms when you study the heart called chronotropic and inotropic. You don't have to go those now, though. That can annoy you in AP2. Big player there. This is the complexity of these receptors. All of those adrenergic receptors, whether it's norepinephrine or epinephrine, are classified as alphas and betas. Don't ask me why. That's just the way they classify them. And you have alpha 1, alpha 2, beta 1, beta 2, and beta 3. I'll point out the ones you're going to have to know. Why this is important for any of you going on, particularly in nursing, when you have to go into pharmacology. You're going to get sick and tired of hearing about beta 2 stimulants and alpha blockers and beta blockers. That's what medicines are. Again, a lot of the medications we use traditionally, there have been a lot of improvements, work through these systems and still do. So you're going to have to understand the pharmacology of, for instance, you're going to see it here, the pharmacology of why the EpiPen works. The pharmacology of why, if you know somebody with asthma and they have an inhaler, why it works. This is where it's all coming from. So this gives you an advantage of when you get to pharmacology, or even if you don't, and if you're in your own lives, you understand what it is. Because when you look something up, I always look up mode of action. It'll say, oh, it's an alpha 2 stimulant, blah, 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 blah. At least you have an idea what that is. Today. Effects depend on which subclass of receptor predominates. Norepinephrine binding to cardiac muscle. This one's important. Beta 1 receptor increases the rate and force of contraction. They should. That's a big distinction. You comment and go over that when you do the cardiac unit in AP2. Here's the one of the EpiPen. Remember fight or flight. Heart accelerates. Respiration accelerates. Eyes wide open. Blood flow is put aside, limited tremendously because it's designed to go to the heart and the skeletal muscles and the liver, and it's taken away from the gut, digestive, and genitourinary system. I've said it over and over again. In order for respirations to increase and the heart to work harder, you need more air. It's not enough to open their throat or open the bronchi. Those bronchioles are very, very tiny. They're microscopic. Okay. So in order for us to open them up, we have to use something that will open them up at that microscopic level. Those are where the beta 2 receptors are found. When someone has anaphylactic shock, when someone has an asthma attack, those beta 2 receptors effectively are firing, if you will, inappropriately. They're being contracted rather than relaxed. In order to get them to relax rapidly, that's what epinephrine does. When you inject it like that, it's a subcutaneous injection. It takes a matter of seconds to potentially save somebody's life, or at the very least, make the severity of that go away. So important. Those are beta 2 receptors. So, part you need to remember, beta 1s accelerate the heart rate, increase force of contraction. Beta 2s basically dilate the bronchioles. That's their big play. There's some other stuff they do, but you're going to see the big one that's important, particularly emergency-wise. I told the other class, that I beg your pardon, beta 2 stimulation, not blockage. So I told the other class, that's when someone has a cardiac arrest, I mean, you could take those defibrillators, if they don't have a heart rate, it doesn't matter. They only work if that heart has some electrical activity. So a lot of times in emergency, when we have somebody flatlined, you can't shock them. You got to find out what's making the heart not work. You got to effectively artificially stimulate it. The injection of epinephrine would go directly into the heart. And then if it got some activity, then you could, if you saw that they were fibrillating, then you could shock them. So understand, it's really important stuff that when you begin to see things clinically very, very soon, because that's the type of thing. And I don't know what they do today or how they do CPR. We used to have to do a thing called a precordial thump here, and effectively you're trying to generate electrical activity, get a rhythm started. Don't know if that's still, for a while they took that away. I haven't re-upped in CPR in a long time. Don't plan to. So if any of you have re-upped recently, you may know. But they offer it here. They have all those, I'm sure you got the same info I did. Did you guys meet Hannah up there? In the Rise Center? You do meet her, say hi for me. She'll know. Moving on. So examples. Nicotinic. When do we care about nicotine receptors? We excite them. Certainly they're excitatory. When do we utilize it? Smoking patches, nicotine gum. The gum isn't something you're swallowing. Nicotine doesn't work. The acidity in the stomach blows it up. What works under your tongue, it absorbs quickly into little blood vessels. That's why sublingual medications work. You can do that in diabetics. They'll get a sugar pill that'll dissolve quickly. They don't have to swallow, it just goes under there. So you're getting some information here today. So they're excitatory. The muscarinic excite, in most cases, inhibition of cardiac muscle. Beta 1s, heart predominantly, also kidneys and adipose tissue, increases heart rate and force of contraction. You'll learn about that when you do kidney, something called renin. It plays a role now very significantly in blood pressure. It's the way we control it. Indeed, one of the medicines that I take works through a pathway involving it. So we're not going to comment on it now. That's the beta 1. Here's the beta 2. Lungs, most other sympathetic targets, abundant. Blood vessels in the heart, liver, and skeletal muscle. That's fight or flight. You're dilating the bronchioles so you can increase respiration dramatically, bring in tons of air because you're increasing blood flow to the heart because of increasing the heart rate. You're increasing blood flow to the liver for energy supply, and you're diverting the blood flow to skeletal muscles so you can fight or run away. All there. Effects are mostly inhibitory, dilates blood vessels and bronchioles, releases smooth muscle walls of digestive and urinary, so they relax. Not going to use them. I wouldn't even worry about the beta 3s. I'm not going to ask you about that. Uh, that's a useful side effect of exercise because basically, you're stimulating sympathetic and it breaks. It's like a fat burn you're doing when you're working out. Best way to describe it. So, alpha 1s, virtually all sympathetic organs, especially blood vessels serving the skin, costa, abdominal, viscera, etc., constricts the vessels and visceral organ sphincters, dilates pupils of the eyes. Fight or flight, eyes wide open. Everything else is diverting blood flow from where you don't. When you're in an emergency situation, your blood flow is heart, liver for energy supply, your sort of your emergency supply of energy, and skeletal muscles. We don't need it in the gut. We don't need it in the genitourinary system. The skin, we're going to cool it with perspiration. Membranes of and this alpha 2's membranes of adrenergic and terminal pancreas. Again, not a big deal for us. It has to do with insulin, and we don't utilize insulin at that particular point in time. That's typically when you're at rest and you're digesting your food. So that's not a big deal to remember. So the ones that are important for us here, the inhibition of the heart muscle, stimulation by beta 1s, the very important beta 2s, particularly when we're looking at the bronchioles and the redistribution of blood. And I think and this is sort of the opposite effect, okay, that you see there with redirecting the flow and opening the eyes. So this is just some examples of some of the agents that are preferred and utilized for this. Hold on. So here's the nicotine I talked about, smoking cessation products. Interesting how they work because it's a stimulant. That's why people can't tolerate them. And if you didn't know, you lower the dose. It starts with a high dose, and then after X amount of time, a week or 2 weeks, whatever, you go to a medium dose, then a low dose for a maintenance dose, and hopefully stop at the same time. It didn't work for me. I used a different product I would not recommend. I don't even know if they still use it. Called Chantix. Here, these are interesting. And again, I don't think we use them, all of them. Now this is the terms. Parasympathomimetic, and sympathomimetic, sympatholytic. Fancy names. Mimics the sympathetic, acts like it. Lytic blocks it. Parasympathomimetic and lytic, same thing. Fancy terms. Don't let the elaborate nomenclature bother you. It's pretty straightforward. It either acts like the sympathetic or blocks its activity, acts like the parasympathetic, or blocks it. Here's one that acts like it. They call them muscarinic agents. Not a big deal because they're acting on those receptors. The one that we probably use, I don't know what the current medication is for glaucoma. This is very, very useful. Okay, glaucoma involves an overproduction or an inability for fluid to drain in what you're going to learn about with eye anatomy called the anterior, sort of like the anterior chamber. It's between the lens and the outer eye. If fluid builds up in there, not only is it painful, it can lead to blindness. So a number of people have this. There's a little canal in the remember that lacrimal bone? There's a little canal in there that allows fluid to go out. It's a tear duct, and next to it, there's another canal. And it allows the fluid to go out. It opens that canal. So whether it's the same, whether they're using this same medicine or something similar, I don't know. But you can see that, so it's not something that's that terribly common. For years, for people with prostate disease, you tried to make it easier for men to urinate. They have a better medicine today that I think works differently on the muscle itself called Flomax. Okay, this was hard to tolerate. The Flomax has been used, very popular over the last 15 years. I had a good part of my prostate removed 4 years ago because of complications from from my treatment for bladder cancer. Thankfully not for prostate cancer. So I was on the Flomax. I don't have to take it. Here are the ones that you definitely don't have to. You already answered this one. Acetylcholinesterase inhibitor. That's nerve gas. That's a chemical weapon made from insecticides. This, I don't know if that's the name of what we're using. This works similarly because it inhibits acetylcholinesterase, but here in just this a sufficient amount to try to compensate for the problems in that very bad disease called myasthenia gravis. I don't think I have any questions about that. And again, I'll go and listen to recordings and I'll go over it. Again, here, somebody with an inhaler, we all do. Okay. This is, most of them contain something in albuterol, whatever the trade name is. When they do it like this, it's a trade name, Ventolin. It just means that's trademarked. And so a lot of people, that was one of the early ones people refer to it. Asthma is more common than you think. That doesn't, when someone has an acute asthma attack, probably unless they have ones that are so severe, they have to use an EpiPen. And I don't know. Typically, they would use their inhaler. My daughter had this for cold-related asthma when she was figure skating. She did for 7 years. Like the last couple of years, it really started to bother her those early mornings on the ice, and the exercise aspect. So they gave her a ventilator, and then that opened it up, and they maintained it with steroids. They had like a steroid inhaler. I don't know if that's what they do today at all. But if you know somebody who has asthma, they probably have one of these. And typically they'll utilize that. Whether they have a second inhaler or something else, I don't know. The other one that we used, this is, and again, these mimic the sympathetic system. Phenylephrine is something, if you take NyQuil or Dayquil or a cold remedy, typically it's in there. It opens up your nasal passageways. You can get them in pill form. Any pharmacy will have them. So if you have a really congested nose, you get some of those, and typically they're mixed with Robitussin, cough suppressants, and Tylenol and that kind of stuff. Commercial cold preparations. This one is safe. Years ago, they made one called Sudafed. Pseudo means false. Ephedrine was the parent compound that amphetamines, or what we call speed, was made from. Amphetamines, ephedra was a particular flower or leaf that was used in a Chinese tea preparation. They found that when people used it, when modern medicine found out about it, it improved their breathing. So they synthesized agents from it. The agent was called ephedrine. The ephedrine, they not only find it did that, but it kept people awake and alert and caused their appetite to be suppressed. So from that they got diet pills, and from that they got something called Benzedrine, which was the first amphetamine. All this is context. These were without prescription. They used it extensively in the military for pilots keeping awake because they flew multiple missions. For soldiers being awake and alert, they gave it to them all the time. They still do use stimulants of this nature for the military. They have to be on missions for long periods of time. They're, a 12-hour shift with maybe manpower is limited or expertise. There's nothing new under the sun. I want you to be aware of it. The trouble why they are now they're a controlled substance is they can be extremely addictive and extremely dangerous. And they pulled the Sudafed off the market because with that and some chemicals you could get at the hardware store and materials you could buy at the hardware store, you could make a factory in your kitchen and make amphetamines or speed. And every so often you hear about one of these speed factories blowing up because the materials are so flammable. There's a whole TV show called Breaking Bad about that. I never watched it. I mean, I was familiar with the process having been a chemistry major. Okay. And they usually were people who were chemists or trained in chemistry who could do it. I used to use an allergy pill that had that Sudafed, and when you started to control it, you have to go to the pharmacy to the window and say, I got a package of whatever, okay? And you give me your driver's license or some ID, and they'd mark it down. It's just, I mean, every so often that would be scrutinized. See, if somebody's buying the store out of that stuff, it's pretty suspicious. Somebody like me is buying it once a month for an allergy pill, probably not so suspicious. And then and they didn't start requiring. That was something that probably happened about 20 years ago. They started to require. I think you can still find it in pharmacies, but like these, I just take a Zyrtec in the morning. It works great for me. And lastly, the propanolol. Propanolol was an original beta blocker. It worked because you were trying to block that. And so by blocking those beta 1s and beta 2s, it would cause the blood pressure to drop. Good thing, trouble was a lot of side effects that were there. So it really it dilated the blood vessels too much. It had a lot of digestive and genitourinary effects. And like I said, we have better blood pressure agents today that work differently. This is the idea of dual innervation and that dynamic antagonism. Nearly every system, and they work together. Like right now, your parasympathetic is predominating. Probably right now, my sympathetic is predominating just because I'm a little more active and vocal and things like that, but subtly so. Okay, the minute you get up and walk out the door here, all of a sudden your sympathetic ramps up. So they're constantly working together. And so again, sympathetic, and the closest thing is fight or flight again and again. A bunch of questions are going to be that in fight or flight, this happens. Your pupils do what? Dilate, constrict, stay the same. Can't be any more transparent than that. Sympathetic, heart and respiratory increase, digestion and elimination slow down. That's where we move the blood to that area. So we take it away from the genitourinary tract and the digestive tract so it can feed your heart, your skeletal muscles, and your liver. The parasympathetic, true now, slows your heart, respiration, rest, and digest. And the big one here is blood vessels have no, read that, no parasympathetic innervation, only sympathetic. They are the exception, the major exception for dual innervation. And because of that, not only is it the only one in blood pressure, that bottom number on your blood pressure, we call that sympathetic tone. That's how taut those blood vessels are. If they're excessive, the bottom number is the big number. If that bottom number goes up, it gets tighter and tighter. Your heart has to work harder. The heart gets over muscular and begins to lose power. It reaches a diminishing returns. A little muscularity is good, keeping it in tune. Gets too big and thick, can't pump efficiently. Heart becomes muscle bound, if you will. You learn more about that in AP2. So that's that bottom number. If it's 120 over 80, this is the 80, that's good. If it's 95 or 100, you're in trouble. Again, that's a heart attack or a stroke looking to happen, period. How do I know? Because that's what my doctor told me when I was 20 years old and weighed 260 pounds. Don't look at me like that. You, me, and 3 other guys could get in my pants. It was like in the circus, the clown pants with suspenders. That's why nobody recognized me at the reunion. So this is the sympathetic. We call it vasomotor tone because those are the muscles going to the vessels, smooth muscles. And it tells you what they do. Blood pressure down, they constrict. Blood pressure up, they relax. And it can move the blood wherever. Parasympathetic is rest and digest. Etc., etc. Slows the heart. Parasympathetic tone. Okay, and that's mostly what we have most of our day. That's parasympathetic tone. There can be overrides. That's fight or flight, and so you have to be careful when you learn about medications, whether personally or with family or professionally, as many of you will. This is giving you the ability to understand that. This is the classic example of cooperative effects. When they talk about the external genitalia, they're meaning sexual arousal. Part of arousal involves vasodilation. Okay, increasing blood flow to those areas, that's parasympathetic. So erection of penis and clitoris. Sympathetic is basically what it switches over for climax or orgasm in the female, ejaculation in the male. So it's both. First starts parasympathetic, concludes sympathetic. And I mean, this is the idea of the sweat glands, thermal regulatory responses to heat. I mean, even though it takes away from the skin a lot of the circulation, there's enough circulation increase in the skin so you can do perspiration because you got to cool the plant. Because fight or flight, you're burning up energy and causing a lot of heat. Okay, it's there. You'll learn about this this is something that's part of it, but I would save it for AP2 to really study it because this mechanism is important. And again, all the increases metabolic rate, needs glucose, utilizing the fats again is something that really coincides with, again, fat burns and exercise and trying to lose weight scientifically. Again, parasympathetic, because it's all acetylcholine, is much more short-lived. Sympathetic is longer because it takes longer to inactivate it. It doesn't have the acetylcholinesterase. There's other enzymes. They're not in that place. They're not right at the synapse. Okay, so that's why, and like we feel it longer, particularly because of the epinephrine and norepinephrine that pours out of your adrenal glands. That's that one. Oh my God, it's like I'll never relax. And this, I can't. You can look through this if you know what goes on here. Those major effects of fight or flight. Just remember, if you know that one, you don't have to memorize that one. It's just the opposite. Fight or flight is as close to pure sympathetic. I'm not going to ask you the little fine points. Eyes wide open, dries up secretions, pupils dilate, okay, respiratory passageways open up, bronchioles dilate, heart increases, respiration increases, force of contraction, takes away the blood flow from the digestive and genitourinary system, increases it to the heart, skeletal muscles, and to the liver, which is your energy. And when you get to diabetics, you'll see this. I had a lot of diabetics, about probably half my practice, 2/3 of my practice rather were about diabetics. About half of them had signs of neuropathy. It comes later for the most part. In men, sometimes they'll get early sexual dysfunction. I had a case with a man who didn't take care of his diabetes. He was referred to me because of foot and leg problems he was having. And what got his attention was all of a sudden, here's this guy, not even 40 years old, big, muscular guy, sexual dysfunction. The sad part of the story, when I saw him 6 months later, he was a shadow of what he looked like. And it wasn't because he was taking his insulin and being healthy. He was on the waiting list for a heart transplant. Sad. Very sad. Didn't pay any attention to it until he experienced sexual dysfunction. And these are lots of the different things that happen. These are little, as you get older, you get what's called orthostatic hypotension. Your sensors don't react quickly to sudden changes. You'll even see me here when I get up to go to the board. I'm making sure I've got my hand on something. It wouldn't be 75 years old. I mean, it happens. It's not abnormal. It shouldn't happen to you, but it could happen to me. And so these things are a little bit different. Okay? Best way to, and early aggressive control was a formula that was developed in a place called the Joslin Center, and it's really significant. When you learn about diabetes, I hope they really give you an idea of what goes on. And if you want some extra information, I'm happy to help. It's really something that if you can avoid a lot of these terrible complications like blindness, like kidneys that being on dialysis, 75% of people go for blindness, 75% of people who have kidneys that no longer work and they have to have transplants or be on dialysis. The common denominator, that's right, diabetes. So I'll get on top of it early. Nothing really here. Yeah, your limbic system could certainly play a role. I mean, you can read through this. All this is pretty straightforward stuff. I'm not asking any questions about it. All the different areas where you have controls on it, biofeedback, we're not going into. And again, high blood pressure is a very good example of a disorder through it. And that's why a lot of the medicines traditionally were treated through this. We don't see them too much more. Like I said, you're using a lot less because of the side effects, and they're trying to work through other passageways. It's my understanding. You'll learn more about it. And lastly, Raynaud's disease. This is interesting. We think it's usually a response to sudden change in temperature, warm to cold. It doesn't mean like today would be a bad day. But my first wife had this, and sometimes it underlies a serious disorder, like in the autoimmune family, like people with lupus have it. Sometimes people with rheumatoid arthritis have it. And with her, she didn't have any of those things. It's just like on a warm day when she could jump into the pool with the kids, all of a sudden her hands would go from normal. They'd start normal here, that color, and she'd get out, and all of a sudden, we call it bilateral and symmetrical, fingers, the same fingers on both sides would go into spasm, and they'd blanch or turn white. And then when the spasm released, there'd be so much blood flow, they get a bluish color. And we used to joke about it, not in medical school. It was called the patriotic disease because they started normal red, then they went to white, and then when there's too much blood flow, they got like a bluish color. So something if I've seen it a couple of times in someone I was married to, but I saw it in other patients. It's more common than you think. When they say Raynaud's disease, it means they really don't know what's doing it. Usually getting very excited or very cold. Okay. When they say Raynaud's syndrome, it usually implies there's something going on underneath. That was the old way. They may have changed it. That's everything. We are finished. Ta-da! So again, if you're coming in on Monday, it will be optional.